Welcome everyone. This is Caleb from TASC at the National Rural Health Resource Center. Today is Wednesday, June 10th, and this is our fifth session for our FY19 TASC Flex Learning Collaborative focused on population health. Today we have Ralph Llewellyn from Ide Bailey and Associates. Let me pull up Ralph's intro from Ide Bailey LLP, sorry, not Associates. Ralph is a partner with Ide Bailey in services as their partner in charge of critical access hospitals. He started his career as a rural hospital CFO and for the last 23 years has been with Ide Bailey, where he conducts operational assessments as well as assisting providers in enhancing financial and operational performance. He also assists providers in developing strategies for maintaining compliance with Medicare and other regulations in the rural setting. Provides charge master, cost report audits, and redesigning projects, conducts reimbursement enhancement studies, and also assists in the development of physician compensation agreements. We have the pleasure of working with Ralph on many projects. He helps us with the Flex Workshop a couple times a year generally, as well as many other projects. So I was really excited that we got to work with Ralph today. Please do take a moment to dial into the conference telephone number and take a moment to complete the polling question so we make sure to continue to improve the educational offerings that we provide to you guys. I believe those are all the updates we have. Our last session will be 2 weeks from today on the 24th, and then it'll focus on telehealth. And we'll get to some of those logistics before too long, but with such a big topic as finance, I wanted to give Ralph as much time as we have. So Ralph, we'll get your slides loaded up and let's go on.
Well, perfect. Well, while we wait there, I want to thank everybody for the opportunity to get the chance to visit with you about two of my favorite topics, population health and finance. You know, I've been fortunate enough to be engaged and involved in the side of the population health financing component since all of the initial ACOs came out with the AIM funding. Think about the rural health kind of models that were out there and are still out there and have definitely expanded. When they first came out, we were fortunate enough to have about 25, 30 different facilities. Initially, I think it got up closer to 50 facilities at one time that we were working with as a financial consultant in the early days of getting these up and running. And, you know, when they first came up, obviously there was a lot of concerns about how do you tie population together with finance and making it work. So I greatly appreciate the opportunity to get to talk to this group about maybe some of the concerns you hear about in the field, talk about some of the opportunities that we see, and hopefully giving you some tools in the homework that will allow you a little bit more talking tool, a little bit more information to help providers make that right step in trying to adopt and move into the direction of population health. So a couple of things I want to start out with is I want to start with the biggest piece, which is the barriers to that conversation. I know that when I have conversations with providers and talk about population health, especially the first time, there's a lot of apprehension, a lot of questions, a lot of concerns, especially if that CFO is standing there. And I want to hear from you guys a little bit about what you guys are hearing when you're having those conversations, as well as what are the positive conversations you're having. And then from there, we'll move into what I see as the conversation pieces, those pieces that we need to be pushing into the hands of the individual providers to help them understand what they can do from a financial and operational perspective. Definitely we'll want some feedback and conversation as we go through this. So the things you're hearing, maybe we can give you some ideas and ways to spark additional good positive conversation out of it. So with that, let's just talk about population health strategies. So the first thing I like to do is just open it up to the group and inquire to you, when you're trying to have these conversations, these initial conversations with providers about the population health, what barriers are you hearing, or what kind of challenges or roadblocks are you experiencing? The more you have to share, the more I can give you some insights on ways to address those. So who's got the first barrier?
*2 will unmute your line.
Perfect. Because I know that some of you are going to hit barriers, because it's the most common challenge is getting them out of the chute. So anybody have a barrier they're willing to share? Well, we don't have any that
Hey,
are being
Ralph.
shared. Yep.
Hello, this is Robert in Texas, and one of the challenges we've noted is just the language around population health and the common understanding. Like sometimes we don't do population health, but then they'll say that, but then they'll turn around and say in the same sentence, at the rural health clinics, they do chronic care management or Medicare annual wellness visits or stuff like that. So just the common language that they're using around population health.
Maybe, am I hearing you correctly by rephrasing a little bit, is that maybe there's just a lack of understanding of what is population health? Because that's sometimes what I see, is that people don't understand what population health is. One of the things we'll talk about is that you don't have to be in an ACO to do population health. There's different incentives if you're into an ACO, but sometimes it's just getting people past that whole conversation that they're not in an ACO. So that's a great point. Any other barriers or conversations that come up?
Hey, Ralph, this is Stephanie from Idaho. I think one of the challenges that I've seen is more recently in the COVID environment, where folks feel like they don't have the bandwidth to even have a conversation about population health right now. And then I think for me, it's being able to tailor population health based on who I'm talking to. So what's the so what factor for a CEO and a CFO versus the so what factor for like a QI person or someone like that. So just kind of knowing what are kind of the more hot topics when it comes to who I'm speaking with, how to tailor my ask.
Okay, perfect. I appreciate the comment on the COVID and the bandwidth. I would say that since the early part of March, mid-March, depending on the part of the country we're in, it definitely pretty much everything got locked down from anything happening if it wasn't related to COVID, et cetera. We're starting to see some of that open up in pockets of the country now. We're starting to get people jumping back into a little bit of normalcy, or what might be the new normalcy. Okay, so that'll be, I have some things in here I think that you can talk about how some things will hit, like the quality person, what they want to hear, as well as things that the CFO wants to hear, and hopefully some advantages for both. Okay, perfect. Anything else? Let's move to the next one. Oh, go ahead, Tracy.
One of the things that we hear sometimes is, particularly from the financial perspective, of this is going to cost us money, or this is going to take care away from the current services that we're doing, or whatever. We're gonna end up losing volume because of this, whether it's inpatient or potentially in the future outpatient services. So why would we want to be involved now?
That is probably the most common one we get. I've actually, unfortunately, experienced CFOs that have told me that population health will only reduce volume, and I will do absolutely nothing to promote that, which is a really sad place when we're in healthcare. Now, there's some opportunities in there that they're not thinking about, and that's the challenge, and that'll be some of the pieces that we'll talk about today. Okay. How about any positive pieces? Are there any good conversations you're hearing, positive components when you're trying to present this, especially to C-suite individuals who are usually the buyers of anything that we're trying to do. Are you hearing anything positive? Or is it mostly the challenges? I'm going to assume most of it's challenges. So with that, I'll just move into the next steps here. Let's talk about some of the things. Most of the providers that we run into that first time, that first conversation, you know, it has nothing to do with their skill level, not even their years of experience. It's across the board. One is there's the fear of change. Why would I do something different than what I'm doing today? Which is scary when what they're doing today isn't necessarily working for them financially either, but it's the fear of that. It's the fear of the unknown. No one else has done it in our area. I've never done it. I'm not sure what to do, all those components. And then it kind of hit that piece that I think Tracy was hitting, and she's dead on. Confidence is that will lead to reductions in services, which in a way it will, but we'll talk about who it reduces services to. Confident it will lead to financial deterioration. I will tell you in my experience, it has not. And confident that this will be the beginning of the end. And, you know, that doomsday kind of piece, which, you know, that has not necessarily been an issue for any of the providers either, just because they got into population health. So what we're seeing, and this all goes back to when we started seeing people going into AIM funding in ACOs, and I'll say it a couple times here, and please keep this in mind. You don't have to be in an ACO to adopt and take advantage of some of the things that are there in population health. So, you know, what is the opportunity? Well, obviously there's the patient-related side of it. And so this goes to Stephanie's piece of, you know, what's the quality side or whatever? Well, it's improved health. You know, we are seeing situations, and I love it when I've been involved in some of my ACOs. Again, you don't have to be there, but using CCM, transitional care management, and starting to share stories about patients that were brink of disaster from a health perspective, and then all of a sudden, within the matter of a relatively few months, their lives being transformed because of chronic care management, other population health, annual wellness visits, things like that. The other piece on the patient-related side is if we do this all right, there is going to be an overall reduction in cost. Again, that's the piece that the CFO side is concerned about and that we've got to be able to address and have that conversation with. Healthcare provided side of it, the upsides, the things that I look at. One, increased utilization of outpatient ancillaries. I'm going to talk about how this doesn't necessarily, if you do it right, lead to reductions in services. For a lot of our providers, it's going to result in an increase. Increased utilization of our primary care, more visits with their physicians, their mid-levels, their PAs, their nurse practitioners. Now, where is the healthcare-related pieces that we're going to see some changes in? There is a reduction in what I would call outside healthcare costs. In my experience, that's where the opportunity has been to reduce costs. It's the things that they're not doing. It's the high-cost things that happen when we don't take care of patients correctly. It can be high-cost pharmaceuticals. A lot of times it's high-cost ambulance transfers, either ambulance or air or ground. Air ambulances can be a significant portion of the Medicare budget in some areas. The other piece is that this is really an opportunity to increase market share. And I'll share some stories that I've seen along the way that really drive some opportunities to grow what we're doing. All right, so financial opportunity. If you do this right, you can increase, I've seen and we can do, increase patient loyalty, increase market share, and we'll talk about how I define market share for that piece. Large cost reductions come from those things that other people do. If anybody should be concerned about cost reductions in population health, it's the big brick and mortar specialty people that if we do things, we're going to try to avoid people getting to that point. Not avoid it by preventing them from getting care, but preventing them from having the need to get to that level. And then the other opportunity, and we've seen this with some of our people in ACO, is the participation in shared savings. That's the only piece you can't get if you're not in the ACO. But there are definitely opportunities. So again, you don't have to be in the ACO to begin doing some of these things. So going back to my CFO days, that's been 20 years ago now. I remember for ages we complained about the fact that if Medicare wanted to control the budget, if others wanted to control the budget, all they had to do was give us preventative services that they would cover, because Medicare and a lot of others didn't cover them. And we complained and complained and complained, and finally we got them. And then when we first got them, and still today, we see that providers aren't taking advantage of them. They forgot that story. Now they're off talking about something else they need. And at times when I work with people at the professional level, they're seeing that. They're saying, well, we heard that, this is what you needed, we've got it, and now people aren't using it. And they're asking for something different. What is it they need, and are they going to use and do? Here's the opportunity. There is money and there is an opportunity in wellness services that can serve us extremely well. So a couple of things that I go back to, and these are very basic, but they really are the core, the working pieces and the opportunities within the organization. The Welcome to Medicare visit. This is the first visit that they get. This is really the only physical you really get from Medicare covered, because the annual wellness visit is not a physical. An annual visit that would be a physical still is not covered by Medicare, but you get this one-time visit and you basically set a baseline and you start putting together plans about how you're going to address those things that the patient should be taking care of from a wellness perspective. The annual wellness visit, one of my favorite things in population health is this, as well as chronic care management. The terminology on this one's really bad. When it says wellness visit, it sounds like a physical, but it's not a physical. And what I tell providers is that it's not only not a physical, but if you're touching the patient, you're doing it wrong. This is not a touch and feel and examine the patient kind of visit. This is one where we are starting to look at all of the things from an assessment perspective and helping them plan out their next year of wellness. What are the screenings they should have? What are the ongoing things that we should be addressing to make sure that we help them prevent things from happening and be more proactive versus becoming a reactive perspective. And so this is just a list here of all the various factors that go into an annual wellness visit. It kind of sets us up for that year. It takes a lot of time for most facilities to do this, but it's not something that the physician has to do all by themselves. In the best practices, there's good LPNs, RNs, aides that are helping along the way, setting up the physician, PA, or nurse practitioner to do their piece and do it in an effective manner. So again, it's not a physical. The biggest piece here when you're trying to get these adopted, because initially a lot of providers struggled with them, is one, the patient. You need to set the expectations with the patient before they come in. This isn't a physical. This is a planning visit. This is something where we're going to work with you to plan out your next year. Medicare covers it. Other payers are starting to cover it, etc. Sometimes it's a dedicated visit, meaning that they come in and that's all they see. Other times, it's a dual visit, which means they're coming in for another visit, like a chronic care kind of visit, where they're coming in for an ongoing issue that they're having dealt with, and they do that at the same time. Sometimes that dual visit, it's a little easier to do it because they've already made a trip in. Some patients will feel a little shorted or like it's not a real service if they just come in for that alone. So it's something you got to work on with your marketing. The other thing is that if you're looking from a quality perspective, kind of down that piece of what Stephanie was commenting about, this is a great opportunity to document so many things in their record from a quality perspective, and capture things that will go into their HCC scores, etc. But the piece that becomes the financial component, because there's a payment for this here, but the real payment opportunity, the revenue source that you're looking for, comes in the preventative services. Because if you do these services right and you plan all the things that they need to have, I've got a list here of all the services. This is part of the homework and some of the listings that you have. It shows you all of these different screenings and the frequencies of when they can be done. Now, obviously, you're not going to do every one of these things on every patient every year, but by setting these up, you basically are getting them on a plan, so they're going to come in and do these services, many of which you do or you could be adding to your organization. So you look here, we've got annual alcohol misuse, some behavioral counseling for alcohol, annual depression, behavioral therapy for cardiovascular disease, cardiovascular screening, obesity screening. So, there's 6 different things there. But that's not the end of it, because you move to another page here with counseling for obesity, you've got diabetic screenings, you've got diabetic outpatient self-management training, you've got diabetes prevention programs that are out there, and it goes on to medical nutritional therapy, tobacco use, lung screening, and the lung cancer screenings, those are things that small facilities can do. There's a CT scan that they run with that. Ultrasound screening, facilities can do their ultrasound. PSAs, prostate cancers, cervical and vaginal cancer screenings, colorectal screening. This gets into all the sigmoidoscopies and colonoscopies. I've had some facilities, when they first got into hitting the annual wellness visit, saw a significant increase in the amount of colonoscopies. I had one provider tell me that he was amazed at the number of elderly men that he is all of a sudden being able to get to come in for their first colonoscopies through the conversation of an annual wellness visit. People that had avoided getting them at their 50 and 55 and 60 age marks, they're now in the cycle of having their colonoscopies done. And so, again, huge opportunities to improve the health because of early detection, but you're also feeding that outpatient side. So it kind of goes back to Tracy's comment about concerned about outpatient services and outpatient ancillaries and things like that. Actually, if we do this right and we provide these services, we can start feeding ourselves with the other work. Now, we may not do some of these things, so we may have to look at adding them, but there's definitely some real opportunity. Screening mammographies, bone mass measurements, glaucoma tests, hepatitis B screen, infection screening, hepatitis C, the list goes on and on. And if you could only gather just a couple of these screenings or services in a year, there's a significant opportunity to be able to jump on this. HIV screening, STDs, infection counseling, flu shots, hepatitis B, pneumococcal shots. It's getting all of these things lined up, every one of them having a payment from Medicare, all of them having potential payments from other payers, and that's increasing all the time. And I think the other piece to go back to here, the other part on so many of these things when they're screening is Medicare basically has changed the methodology of out-of-pocket, so most of these don't even have an out-of-pocket obligation, because a lot of times the concern is, well, that's going to cost me a few dollars. That's going to cost me a lot of dollars. Well, a lot of the screenings don't have co-insurance and deductibles. So not only are you getting them the right care, you're getting the right care at the right cost point, and there's quality going on. We're appeasing and taking care of that CFO and CEO's concern of that financial side. But this is the piece that's so often missed. It's the concern that if I do this, people aren't going to need services. Transitional care management. This is meant to keep people out of the hospital as far as a readmission and help transition them back into the out of hospital setting. This one here does have the potential to reduce some of your inpatient days over time because you are preventing some inpatient admissions, but it has not been necessarily significant enough to have dire financial impact on providers I've worked with. They've noticed some slight reductions as they've had improvements in their readmission rates. The piece I'd argue with CFOs and CEOs is that, at some point in time, even critical access hospitals are going to get penalized for readmission. So this is definitely, in the long run, is the right thing to do and still needs to be done. But it's something you get paid for also. So you get paid to do this transitional care, the 30-day period, to help transition that person back into the outpatient setting, the home setting, and helping them, making sure that they have their meds and they have all the things that they need, doing their follow-up visits, all of that. So great opportunity to, again, get in front of the patient. Chronic care management. This one here, Stan, this is one of my favorites. It's really meant to help those patients that have multiple chronic conditions. And, unbelievable, great opportunity here. What we've seen here is significant improvements. And through my ACO work, which is where I get more hands-on with the providers through the implementation, what I have seen is significant improvements probably in 3 areas. One is diabetic management. Patients that have significant reduction in their A1C and everything goes around that, and just the quality of life that goes with that. I remember working with one provider in my ACOs where they had a patient who was continuing to decline. Lots of issues going on, and somebody in the family passed away, and this person happened to be a daughter of theirs that passed away. And this person was the major caregiver for the grandchildren. And now they were concerned because what if something happens to me? Who's going to be there for the grandkid? And that was the spark to get the person engaged to manage their diabetes. And through a series of several months, was able to reduce not only the A1C, but drop a significant amount of weight through just little minor pieces and little steps along the way. But that ongoing connection of, you only have, a small period, less than an hour a month, typically, that's being engaged here. But they were driving enough changes in the patient's life. They lost weight, their mobility improved. Now they're feeling very comfortable that they're going to be there. And those are the types of things that happen. That's the real quality side. That's the piece that gets the quality people in there, and now going to the other side of the dollars and cents are also there because they're getting the bill for that. And this patient is now also making all their visits. So a lot of times people miss a lot of visits. Chronic care management is, are you getting to your visit? If you didn't, can I get you rescheduled? In a way it sounds like it's a little bit of a hounding piece, but it's actually a holding of a hand and helping people as they move along. Chronic care management, definitely all kinds of things here. Patient compliance, medication compliance, all kinds of components along the way as you're going through this whole piece. Increased clinic visits because people are getting in sooner. If they start to identify a potential problem that could end up with an emergency that requires an air ambulance or something, they're getting them in before it's the emergency and dealing with it more often at that local level. So lots of positive pieces here. Now, chronic care management does have an out-of-pocket obligation. That is sometimes the pushback that they get from the patient. But the piece that I use is that, if you look at, I think it's about $8 a month at a cost to patient, and that varies by market and year to year. About $8 a month. If you avoid one inpatient admission, the out-of-pocket cost of an admission is $1,300, $1,400. So if you can, admission every X number of years for that patient, it's going to more than pay for itself. And they're going to have a better quality of life. So there's things that you have to really start having a conversation with the patients early on about, yeah, there's some dollars, but there's a reason. Now, the services that we talked about here, I've mentioned already, these are definitely things that can be done by our small providers, even some of the smallest. You can have, you can have some facilities that maybe don't do scopes and things like that, but they can still do some of the lab tests. They can still do some of the other evaluations. They can do the CCM. They can do the annual wellness visit and build that all there. That's what we're hopefully going to see will increase or at least maintain the total volume of outpatient services that we're doing. We're going to change some of what we're doing, but that's one way that we're hoping to help maintain or protect that line. Now, so basically the best practices is developing a wellness team and really laying out, services, processes, activations, and monitoring. Processes are really important in this, especially in the annual visit and the care management. A lot of facilities really struggle early on when they start trying to do annual wellness visits. So having a physician provider on to talk about the process and the time and everything, really a big deal there. And it works if you can get a physician champion. You really need someone that's there from a physician perspective to be the champion. What I like about it is they provide a lot of feedback for us to listen to. And if they're part of establishing the processes and putting things in place, when something doesn't work right the first time, they don't just throw it all out because they've got some vested interest in it now. They start working on changing the processes, updating the processes, and continuing forward. So great opportunity there. The other part that when I think about population health, and if you do it right, is you really have an ability to improve brand loyalty, which goes back to how do I grow market share? Because in the past, market share was all about how do I find a patient and then figure out how to do every service that we possibly do to every one of them. And under population health, it's how do I find all the patients that need services and then provide the right things to them. So I need more patients because I'm going to do less things per patient, most likely over time. But how do I capture more of them by building brand loyalty and doing all the right things at the right time? So with that, you look at, the way to enhance things. CCM, chronic care management, is a great way to have that conversation with the patient on a regular basis. The stories I've heard in the ACO side of things is that some providers have actually had somebody call and say, I don't use your clinic anymore. I'd like to establish with Dr. So-and-so. And, my friend Mary uses you, and she's getting this one service. When you call and you're making sure she's getting what she needs and you're taking care of her, that's what I want. These can be people who have left your area for some reason in the past, and now it's a way to bring them back. It's the conversations they're having at the coffee shop about my doctor's calling me and taking care of this and taking care of that. Nurses calling, they're checking on me, they care. It's a whole different piece. Annual wellness visit, again, getting all that cost. Then keeping them out of the hospital. And so as you lay these out, you continue to add loyalty from the word of mouth, but you also use it in your story lines and your marketing materials and things to share success stories when possible. Again, the whole goal, trying to increase the number of people you're taking care of versus the number of services you do on each individual patient. And with telehealth and all these other things out there, we know the competition is going to be trying to do these things if we're not trying to do them. So a great way to even be a little bit more preventative and defensive. All right, cost of care. So if you do these things, what we have found in the ACOs that I've been working with, the ACO providers, which is the ones we have the data for most, is that, you really are trying to keep things local. Local preventative, local provision of care, because hopefully we identify potential issues that could get worse and require somebody to leave our area, go somewhere else for services. That's a big deal, that we can keep the things local. Again, the people that need to be worried are our referral sources, the big box, the big bricks and mortar places. We monitor the effectiveness of expended costs over time. If you're in an ACO, you get a lot of reporting that helps you identify who are your high-cost patients and things like that. I remember one case where I had a patient in one of our ACOs who had about a $15,000, $20,000 a month pharmacy bill. And the local physician wasn't even aware that they were on the med. And the conversation came around, what med are they on? It happened to be something that had to do with some lung disease. And it was something that came through some work that they were doing with a provider at a university system. And the physician commented that, he knew of the med and knew that it was only effective on about 4 to 5% of the patients that actually use it. So the conversation came down to, do we know what response or what effect this is having on the patient? It wasn't that we wanted to get rid of it because it was just a cost, but it was more of, if we're spending that amount of money, are they in that 4 to 5%? Because if they're in the 96%, we're not seeing any benefit from it. Should we be trying something different that might have a different cost factor, which could be higher or lower, but it would have a different cost factor? Now, at the end of the day, this patient was in the 4 to 5%. But the important part here wasn't the fact that they were not able to reduce a cost, but they knew what they were looking at and they understood that they were being good stewards of the dollars. You do that often enough, you're going to start to identify opportunities to start driving down some of the costs. And so the whole goal, as we do more prevention and things like that, is we're trying to prevent or curtail the need of high-cost items because they're no longer needed or they're not appropriate. Ambulance, intensive high-cost intervention, pharmaceuticals, all of that desire is to drive down those costs. And when we think about our average rural provider, they may or may not have the ambulance. They don't have the air ambulance hardly ever. They're not doing necessarily always the high-cost intervention. They're not usually the cardiac cath lab or the big ORs and the extensive, way out of line or way out of realm of normal cost for like chemo and things like that. And then pharmaceuticals. They're not the pharmacy usually. It's someone else that's providing that. So doing these things right, they're pulling the costs out. If we're fortunate enough to get this done right, they're pulling not the sum. In my experience, again, having worked with the ACOs that I did, and I worked with day-to-day with 8 of them for a couple of years, a couple of others beyond that, I did not have a single facility that went backwards financially because of the ACO. I had one that was struggling some, but that was not an ACO-driven issue. It was an ongoing thing that was already there. So a little bit of summary, and then I want to open it up to some conversation and make sure that we're addressing the things that you guys want to talk about as you try to, catch up with providers and get them engaged in this. Is that, bottom line, there are financial opportunities. It's not guaranteed. There is work involved, especially if you get into an ACO because there's a lot of tracking and a lot of things that have to happen there. But there is opportunity, even for that provider that is not going to be in an ACO. There is opportunity to increase the number of preventative services, both in the initial annual wellness visits, chronic care management, things like that, as well as all those other things that we can add on to in the preventative side. But there's opportunities to do that. Done correctly, I will argue all day long that there is an opportunity to improve your brand awareness and brand loyalty in your market. You need to take advantage of those opportunities by, marketing them, promoting them, keeping them in the forefront. But there is a real opportunity there. And I think the next set of bullets is really the piece that we got to be careful of, is that, when we talk about non-believers, one, they need to understand there's some opportunities. But the other part is that it's here to stay. Population health isn't all of a sudden going to go away. It's only going to continue to increase in its importance, and if we're not doing it, our competitors are going to do it, and they're going to figure out ways to do it without even having to come into our community. To telehealth, whatever, e-visits, they're going to figure out ways to promote those services one way or another. And ultimately, future payment programs, even though we haven't been hit with them much in the CAH realm yet, eventually people are going to look at ways to adjust our payments based on our cost of care as well as our quality. And we have to start figuring out how are we going to address that so that we can make sure that we are a player in the market over the long haul. So with that, Caleb, I'd like to turn it, back open to the group to maybe solicit some conversations, spend, a few minutes to talk about ideas, concerns, additional pushback that maybe they're getting.
Yeah, absolutely. So *2 will unmute your line. We have had some conversation in the chat box talking about evaluation and just measurement and statistics and being able to demonstrate those outcomes, which I think is a great point. Both for Ralph's comments about those services that are reimbursable or chargeable. My experience, you have a fair amount of opportunity in the non-reimbursable world as well. Some of those diabetic self-management classes, even if you're not charging for them, they have great return, and the outcomes are similar to what Ralph was talking about with the wellness visits. There's really, really great benefits to having those available to your population, to your community. If that happens through the hospital, great. There's just real benefit. One of the added benefits is being able to say from a hospital standpoint of, we're interested in your health. And that will generally keep patients around too. So out-migration isn't so great. All of those things. It might have a negative on the cost report, for that CFO, but if more people are staying in your community receiving care, it's beneficial.
Yeah, I will say that if you can keep the patients in your community and promote these services, some of them don't have a large amount of additional payment on them, but I'll take a little bit of payment hundreds of times a day or a couple thousand times a week if I can do that. It's getting that incremental piece. Obviously, you get into things like colonoscopies and some of the imaging scans. Those are hundreds of dollars a piece, and those are dollars and cents that start to hit your bottom line. That keep people in the community. Having said that, I deal with a lot of CFOs that it's a real challenge. I mean, the one that told me that they weren't going to do anything that was going to do anything to reduce the cost of population health is someone who I normally would say is pretty astute from a financial perspective, but they weren't understanding the big picture of market share and competition and all those other things that are going to come to light at some point.
Yeah, I think this is great in that it does. We are starting to see some of those changes in wellness and chronic care management that, like you said, we've been asking for it for a long time. It's starting, so that's a great initiation of population health. And to Robert's point earlier, maybe you can call it whatever you want. It's a beneficial service to help your community. And if the term is off-putting somehow, some reason, then we can talk about it differently. Sorry, Joe.
Mm-hmm. There's a lot of conversation in the chat about, tracking and stats and things like that. Those that are in an ACO model tend to have a much better opportunity to track because most of them have some sort of module that allows them to track not just the things that they're doing in their organization, but they're able to track the cost and the spend for when they're at any entity. regardless if it's theirs or, somebody else's, because Medicare releases that data as part of an ACO. So if you're part of an ACO, there are some things that are a little easier there. Otherwise, you've got to rely on your own EMR and other type of reporting tools to try to track that, which is possible, but sometimes maybe not as robust. And really, it's a bigger challenge to figure out where those external dollars are at and where the savings are and how you're impacting that over time.
Yeah.
Hopefully we'll get better data from CMS over time on that.
Hey, what other questions do we have? Oh, go ahead.
Yeah, this is Terry. I had a couple of comments. One of them, and I put in the chat box, that I recently had a virtual wellness visit. Basically, my insurance plan basically had and it was really interesting because there were several reminders. I couldn't back out if I'd wanted to because they were so persistent. It took about 20 minutes over the phone, actually, they were using. And it was, I've had one other wellness visit, and this was so much better. And I talked to the wellness nurse about it, and she also indicated that the telehealth visit was way superior in her attitude as well. And so that's where everything is going. And whether or not folks are looking at Medicare patients, I was on a call last week with one of the medical leaders of United Healthcare, which is the largest of the insurance companies. And this woman was basically indicating that they didn't care what CMS did on telehealth payment, but their intention was to do wellness visits, chronic illness management, and basically urgent care online. And she just basically said, we're not coming back from there. So my insurance company is Humana, and they're already doing it in that regard. So I think there's just another real jump forward here. Whether you're in an ACO or not, rural hospitals and clinics are going to have to figure out how to do this, and there's a funding mechanism for them to do it, and it's going to continue.
Absolutely. Yeah. Just the wellness. I mean, because, I've got family members that had to do the same, through the COVID, do their first remote visit to telehealth, and such. My mom, who I would have never thought would have been accepting of that, we had a conversation yesterday because she's got a couple things she's been dealing with, and she's going to actually have to go and do an in-person visit this week. But after that, she's agreed with me that in the future we're going to try to do everything remote because it's just easier for her. She's more secure that way. It's just a lot easier for her to do that, and that's where it's going to go. Not just in population health, not just in telehealth, wellness visit. It's going to be everything. Our firm, we actually have an app that our staff can utilize to do telephone visits, have been able to do it for a couple of years. And I have a couple of staff that live a little bit more remotely, have young kids, and they say it is probably the best benefit that we have in our whole organization. They've been on vacation in the middle of nowhere and had a kid that ended up with swimmer's ear, and they were able to do the visit while they were on the side of a highway, and had the script or whatever they needed to have filled when they got to the next town. And you'll be able to do wellness visits that way. You can.
Yeah, that's
Amazing.
Pretty nifty. What other questions do we have for Ralph? I know there are a lot of issues surrounding finance as it relates to population health. Also, is my voice better this way? Joey says it's better.
Well, I think the piece is that, when you first have this conversation with them, is expect some pushback. But if you can at least get them to entertain the conversation, to say, let me show you some things where we think that you can get some more visits. We can get you more services. And with the goal that over time, yes, there'll be a reduction in services, but we're going to take those away from your big competitor by, trying to prevent them from having to go there and having them more promoted to stay local for the things that we can take care of because we're going to catch things earlier.
Yeah, and I thought about it just as the hospitals have been operating under this payment methodology for a long time, and things change slowly, and it's starting to change slowly. I think of how much education and outreach and engagement was needed to switch over to ICD-10, and that was a very hard and fast CMS. This is what you're going to do on this date, and it was still a huge, hard push. There were still hospitals and providers and coders not wanting to switch because they'd been told so many times it wasn't going to happen, so they were dragging their feet. But think of all of that push and how hard that was. And this is, kind of voluntary, and not everyone sees it and understands it, and it's complicated, and it's such a difference from providing care the way they have for the last 20, 30, however many years. So it's going to be a little more difficult to get them on board with it.
I think oftentimes, when you're talking to multiple people in the organization, is you have to figure out who is that informal, sometimes, because they're not always the formal leader, but who's that informal innovator in the organization that can get everybody's, attention and has enough either formal or informal influence to be able to keep that conversation going. Hate to pick on my CFOs, but sometimes they're the biggest challenge. So I got to get somebody else that can see, the potential to increase volumes and things like that, because that CFO sometimes just gets in their head that it can't go anywhere.
Right.
So I'm pretty tough on my counterparts.
Hey, Ralph, let me jump in again. This is Terry again. I would agree with you totally that particularly if you've got a room full of CFOs or if they're significantly represented in the audience, that you really do have to build it into dollars and cents. And one of the things that we found, I think, looking at, as I've talked to many accountable care organization leaders, is that for the first time they recognize how much out-migration for care is actually occurring. Care that could be provided locally. It's significant. In many cases, it may be half. They're losing half their money. It's going out. So I found it sometimes effective not only to sell population health, just on its merits, which should stand alone in that regard, but that it is, and I really liked your point, it's an opportunity to keep people locally, to brand yourself, to reach out to the population, that piece has got to be done. If you're going to reduce your inpatient revenue, you've got to make up for it on the backside. And what we know from the ACOs, as you pointed out, they can do that if they're intentional about it.
Right. So, one of those, I was going to comment about, some of the work that you and I have seen with ACOs. With the ACOs that I work with, I have a couple of I've been working with now for, must be about year 5. What we look at there is their out-migration of services, and we start, figuring out not so much where their spend is, but mine is what services or patients are you losing and where? And are they things that you do? So I do a lot of analysis looking at specific DRGs. Why are you only getting 50% of this DRG for the Medicare population in your area? What's the other facility doing? And here's the names. Can you figure out why they went there versus coming to you? So when you're in an ACO, there's that added component of you've just gotten access to what I believe is probably the most powerful marketing tool at a fraction of the cost that it would be if you tried to actually buy something like that. And you can look at it from scopes and types of conditions and all kinds of little slicing and dicing, and it's quite revealing when people find out. I've had some find out that that it was actually one of their own doctors referring somebody outside because they didn't care for one of the other docs. And then you start saying, okay, what's wrong with our system that we didn't know that one was, was so concerned about the care or whatever that they weren't referring it internal. There's so much to be learned in population health.
I want Andy to put up the action plan template, and we'll talk about that just a little bit. As we do, as you guys develop questions for Ralph regarding finance and billing stuff, I just wanted to put this on the screen as we're running out of time for this session. We are looking at scheduling an office hours session for the collaborative to help anyone who wants assistance developing their action plan for their learning collaborative. We kind of thought we would have time throughout these sessions to do this, but after thinking about it, I think we'll schedule a separate section for office hours for those who would like to attend a discussion session like this, and we'll kind of go through some activities and fill in some mock leads and timelines and help with outputs and outcomes. And then I think we'll also offer one-on-one sessions. So if Jill or Crystal or anybody would like to schedule a time one-on-one with me, then we can get some time individually to help you guys fill out those action plans. I think they'll be really beneficial as we tie all of these sessions together with our subject matters like Ralph and Tracy and Rhonda to really spend some time and devote some time to that action plan so you guys are able to implement some helpful and beneficial actions related to your Flex program. So I wanted to capture that before people started falling off for the day. So more info to come next week is what we were thinking about it, but that is NRHA, and we don't want to cause anybody to miss one or the other. So we'll find a time that seems to work best for everyone. All right. So this is our action plan template. It is available in the file share box there on the left, and we'll also put it in the downloadable files in the Teams world for you guys. But we wanted to put that on the screen as next session on the 24th will be our last learning collaborative session that is focused on telehealth. So there will be an aspect of all of this as well as Terry's discussion today in that session. Please do take a moment to complete the exit polls as we want to make sure our sessions are beneficial and helpful to you guys. I would like to thank Ralph from iDaily for taking the time to create the presentation as well as take the time to help educate us and inform us on that stuff, and take the time to have a conversation with us as well. Ralph participated in a few of the sessions just to have a better understanding of the format and function, which I really do appreciate. Any other questions, comments? And please do know that this isn't the last opportunity to ask questions and to get some clarification. Either send questions to me or post them in the Teams world, and we can either get some clarification from Ralph or help answer those questions for you guys.